Hi, good day everyone. Today I'm going to talk about non-thyroidal effects of anti-thyroid antibodies. I practice at Magna Centers for Obesity, Diabetes and Endocrinology at Bangalore. I'll start by thanking Dr. Matthew John for giving me an opportunity to speak at this meeting. Sorry we couldn't be there at Trivandrum for this event. So what are autoantibodies? So when you look at autoantibodies per se, they are nothing but antibodies, but they are directed against self antigens. So usually what happens is that B cells and T cells in our body, which are responsible for immunity, are able to differentiate between self antigens and microbial antigens. So this is something that they learn during the course of development of the immune system. So the B cells and T cells which react to autoantigens undergo anergy, or they are eliminated from the body, or they are quiescent because of various checks and balances. So this is akin to the cop who's enforcing the lockdown during these COVID days. So normally they do not react to you, driving around in a car, but during lockdown 1 and 2, they were stopping you and asking you questions, isn't it? So this is very similar to that. So the B cells usually do not react to autoantigens, but then, in some special situations, they can react. And when you look at autoantibodies, they need not always be harmful. So antibody sialyation and glycation will determine whether it's pathogenic or not. So there are antibodies which are protective as well, rather than being harmful. So why are autoantibodies produced in a given individual? So one of the reasons could be these individuals are producing autoantibodies are actually, are genetically predisposed because they have certain mutations in their basic genes which encode for the immune related functions. For example, HLA class DR3, CTLA4 receptor, PTN22. So all these are immunological genes which are very important for regulation of the immune system. Any mutations in these genes would predispose an individual to produce autoantibodies on an average, much more than others who don't have these mutations. All right. Women are also more prone for autoimmunity. So this could be partly be explained by the sialyalization I was talking about earlier. Estrogen has been shown to, decrease the sialyalization, and when you decrease sialyalization, you actually increase the pathogenicity of the autoantibodies. So this is something that could be at work, though there are several mechanisms. One does not really know exactly what lies behind women having more autoimmunity than men. So promoting factors for AITD could also involve exogenous factors. So I'm talking about autoimmune thyroid disease in particular here. So high iodine intake in the form of compulsory iodization program that is there in our country could be playing a role. Infections could be playing a role. Environmental toxins could also play a role in higher prevalence of autoimmunity. So how do autoantibodies cause tissue damage? So there are several mechanisms. So one of the mechanisms that we encounter in endocrinology very commonly is the TSH receptor stimulating antibody, TSI, what we call. So that is there in the upper left panel. So you can see that basically the antibody binds the TSH receptor and stimulates the thyrocyte to produce more thyroid hormone. So you could have other mechanisms of autoantibody mediated damage to the tissues as well. So these are 6 or 7 which are considered generic methods of autoantibody causing tissue damage. So one of them is stimulation of autoantibody. So direct lysis of cells could also occur. For example, in idiopathic thrombocytopenic purpura, there can be direct lysis of platelets. So how do thyroid autoantibodies cause thyroid dysfunction? So before we understand, how they are important systemically, we would like to know how thyroid antibodies are causing thyroid dysfunction within the thyroid gland. So, that there are endogenous and exogenous factors which are causing autoantigen presentation to APCs, by antigen presenting cells, and then you have these antibodies being produced. When you look at Hashimoto's thyroiditis, you have a lot of autoantibody being produced, namely thyroid anti-TPO antibody. So some of the autoantibodies, some of the anti-TPO, not all the anti-TPO, some of the anti-TPO may be complement activating. So that is, it may belong to IgM or IgG1, G2, G3 subclasses, where it can actually fix complement and cause lysis in thyrocytes. This is seen more in animal studies rather than in humans. In humans, clear evidence of autoantibody mediated complement activation is not seen in vivo. But more validated methods include FAS and FAS ligand mediated apoptosis and perforin mediated apoptosis, which does occur in Hashimoto's thyroiditis. So these are methods by which Hashimoto's thyroiditis progresses to cell destruction and thyroid dysfunction. On the other hand, in Graves' disease, we have got clear evidence that the autoantibody that is produced, that is TSH receptor antibody, can actually act on the TSH receptor and behave like TSH itself. So it can mimic TSH at the TSH receptor and cause overactivity of the thyroid gland. So you have hypermetabolic features in those who have hyperthyroidism. Coming a little bit more into detail, so these are the three main autoantibodies which are well studied. Apart from this, you have autoantibodies to sodium iodide symporter. You can have autoantibodies to pendrin. So, and some other autoantibodies are also known, which are against the T3 and T4 as well. But these autoantibodies are not quantitatively very common. They are not, their prevalence is very low, and they are not clinically important. But these are the three thyroid autoantibodies which are considered clinically significant. So let's come to anti-TSH receptor antibody. So the anti-TSH receptor antibody is located on the cell membrane, and even without tissue destruction, antibodies can be produced against it because it's present on the cell membrane. So there are oligoclonal and antibodies which are directed against different epitopes are produced. Mainly IgG1 subclasses produce. They do cross the placenta. Being IgG, they do cross the placenta. These autoantibodies are present in 90% of Graves' disease patients and about 10% of Hashimoto's thyroiditis patients. Okay, so they have well-defined effects on Graves' disease. They also have well-defined effects on Graves' orbitopathy. So, meaning by that, the thyroid autoantibodies, TSH, anti-TSH receptor antibody, have got a clear pathogenic role in thyroid orbitopathy, which is an extrathyroidal disease. So let's come to the other two antibodies, anti-TPO and anti-TG. So anti-TG is located intrafollicularly, anti-TPO is located intracellularly. So they are released after, typically the anti-TPO, which we assay most often, is released after thyrocyte disruption. And you can have a polyclonal, and both of these things are polyclonal. They are not oligoclonal like the TSH receptor antibody. They can be of IgG1, G2 or G3. In fact, the IgG4 subclass predominates. What is the importance of this? IgG4 does not fix complement, and then it may not be pathological through complement fixation. Okay, and both anti-TPO and anti-TG can cross the placenta and could have potential effects on the fetus. So if you look at anti-TPO prevalence, it's present in more than 80% of Hashimoto's thyroiditis. So it's diagnostically important, very, very important when we want to diagnose Hashimoto's thyroiditis. Most people with Hashimoto's thyroiditis will have anti-TPO positivity. Okay, but it has got several ill-defined actions, and the mechanism of action is not known. So the systemic effect, non-thyroidal effects of anti-TPO are not well known, are not well characterized, I would say. We cannot say for sure that anti-TPO is causing this, though anti-TPO is highly prevalent. If you look at the prevalence in the population of anti-TPO, it is close to 10 to 12%. But if you take individuals who have other autoimmune disorders like rheumatoid arthritis, type 1 diabetes, or Crohn's disease, the prevalence reaches somewhere between 30 and 40%. So if you look at type 1 diabetes, 40% of them have autoantibody positivity, anti-TPO positivity. What could this mean? This just means that these individuals have common genetic predisposition for autoimmunity. And you all know that thyroid autoimmunity is the most common autoimmunity. So it's not surprising that they have higher frequency of thyroid autoimmunity. So, but the clinical significance of whether these thyroid autoantibodies affect other diseases or other organ systems is not known. So here is a pictorial summary of what the previous slide was talking about. So the TSH receptor is located on the surface of the thyrocyte, anti-TPO is located intracellularly, and thyroglobulin is located follicularly, intrafollicularly. So you can see here in the panel B that the TSH receptor is shaped in the form of a exogenous portion, which is the A subunit, which is the extracellular portion. And then there is an intracellular portion as well, which has got 7 transmembrane domains. Okay, usually the extracellular TSH receptor subunit can get shed from the thyroid gland, and specific antibodies which bind to and activate this TSH receptor can easily be produced. So here is a closer look at the TSH receptor. So you can have a situation where subunit A can be the main autoantigen for autoantibodies. So the most important extrathyroidal effect of thyroid autoantibodies is thyroid orbitopathy. Approximately 40% of patients with thyroid disease are affected by eye disease. They have varying degrees of eye inflammation, redness, swelling, proptosis. It affects 40% of these individuals. So, importantly, this eye disease runs an independent course very independent of the thyroid disease. It may not overlap with the thyroid disease. Thyroid disease might have occurred years before the eye disease, and vice versa also could occur. So when you have you can have a situation where you have active eye disease going on for 1 to 3 years, and then it goes into an inactive phase where there's fibrosis, accumulation of lipid inside the orbit, which can be a permanent scar. So patients who develop thyroid orbital inflammation carry the scar of proptosis throughout their life, actually. So there is orbital inflammation, orbital fat accumulation, orbital muscle hypertrophy. These are typical features of thyroid-associated orbitopathy. So there can be interaction between TSH receptor and IGF-1 receptor in orbital fibroblast. So this is a finding with enormous therapeutic importance. Earlier in the slide, I said that 40% have Graves' orbitopathy. If TSH receptor are present in the orbital fibroblast, why don't everyone with Graves' disease develop orbitopathy? The difference could be because of IGF-1 receptors, actually. So TSH receptor and IGF-1 receptor act as functional co-receptor complexes within the orbit itself. So the orbital fibroblast acts as an immune cell inside the orbit. It can become an adipocyte. It can actually produce a lot of hyaluronic acid. It can actually recruit T lymphocytes and B lymphocytes into the orbit and trigger a severe inflammatory cascade within the eye, and then cause both redness, swelling, and proptosis. So we have now clear evidence that teprotumumab, which is an anti-IGF-1 receptor antibody, completely blocks the effect of TSH receptor antibodies in the orbit. So there is TSH receptor antibody which binds to the TSH receptor, which is present on orbital fibroblast, but it also requires an IGF-1 receptor which acts as a functional co-receptor. But if you block the IGF-1 receptor, you are ameliorating the inflammation. How strong is the effect of teprotumumab? You can see that the clinical activity score dramatically reduces. You can see that 70% of patients at the end of 24 weeks of receiving teprotumumab are better, whereas not even 20% are better in the placebo group. This is the RCT, which was published in 2017. So, and we had an RCT again published, studies done in the United States being published this January 2020. And the left panel shows the teprotumumab blocking the IGF-1 receptor and preventing orbital inflammation from occurring. So we do have this particular therapeutic agent. It is licensed for use. So the starting dose is 10 milligram per kilogram body weight. And then you give the same infusion every 3 weeks for 7 times. So at the end of 24 weeks, you get dramatic improvement in not only inflammation, redness and swelling, proptosis also reduces. Typically, glucocorticoid, the best result that you obtain with glucocorticoid therapy is actually subsidence of inflammation. You don't get a reduction in proptosis. So proptosis reduces only by 0.6 millimeter in glucocorticoid studies. So definitely there is a heaven and hell of a difference when you use teprotumumab in the treatment of thyroid associated orbitopathy. So what about thyroid autoantibody anti-TPO more than 1000? I think, all of us have patients coming to us and showing a report which says the anti-TPO is more than 1000. So I would liken this to this crowd of Elvises. So patients and sometimes clinicians think that everybody is Elvis, all right? So we are not so discerning. But then rarely some researchers also think that everybody here is Elvis. So the reason why I'm bringing the analogy of Elvis is that anti-TPO antibodies are polyclonal and polyspecific, meaning by that they are non-specific. They do not actually cause any particular disease. They are just there, right? So they are pathological in those with the disease. So it basically means nothing. So if you measure anti-thyroid antibody, it does not mean that the patient is going to or likely to get XYZ disease. You need to follow up the patient and see whether they develop. It may be that it indicates it's a risk marker rather than being a causative agent. There are one or two slides I want to show you about anti-TPO and pregnancy and fertility. So there are a lot of observational studies which have shown that those who have TPO antibody positive have to 3 to 5-fold increase in overall miscarriage rate. So statistically significant relationship between AITD and increasing pregnancy loss have been found, approximately 3-fold in women with AITD. There could be hypothetical links between thyroid autoantibody and fecundity. That is, thyroid antibodies may be a risk marker of generalized. There are 3 ways in which they could be linked. One is that thyroid autoantibody may be a marker of generalized autoimmune dysfunction, and thyroid autoantibody may cause euthyroid women to go into some kind of mild hypothyroidism during pregnancy, causing pregnancy losses. And thyroid autoimmunity is also a risk factor in infertility by unknown mechanisms. We really don't know what could be the mechanisms. So in this particular study, which came out in 2006, this was by Negro et al. This came out when I was doing my DM around 14 years ago. So the percentage of miscarriages, this was not a randomized study. It was an observational study where we looked at TPO antibody positive individuals and TPO antibody negative individuals. So a portion of TPO antibody positive individuals were treated with thyroid hormone. So when we treated a small portion of patients, what they found was that the risk of adverse fetal outcomes reduced massively and became similar to that of TPO antibody negative individuals. But this particular finding could not be replicated later on. So the 2012 and even the present day recommendations recommend that there is no role for IVIG therapy, there is no role for levothyroxine automatically in those women who are euthyroid, that is TSH less than 2.5 and thyroid antibody positivity. So of course we all understand that TSH more than 2.5 is considered hypothyroidism in the presence of anti-TPO positivity, and we treat these women during pregnancy. So the only thing you need to do when you have a patient who's planning pregnancy and or pregnant already with anti-TPO positivity is that we need to follow up the TSH values. So anti-TG antibodies are helpful in follow-up of negative, of TG negative differentiated thyroid cancer patients. So anti-TG antibodies are present commonly in autoimmune thyroid disease and even otherwise. Their main problem is that they interfere with thyroglobulin assay. Thyroglobulin, as you all know, is used to follow up thyroid cancer patients. So in the persistence of TG antibody or increasing titer more than 1 year after thyroidectomy indicates that there could be recurrence of the thyroid disease. This is something which has got some merit to it. Apart from this, there are several other conditions where thyroid antibodies have been reported to be causative. For example, Hashimoto's encephalopathy, you have autoimmune urticaria. But in all these conditions, there is no definite proof that there is a link between anti-TPO antibody positivity and the disease itself. They are all associations rather than causations. It could be because of the common soil of autoimmunity that is present in all these conditions and thyroid autoimmunity. So the stay-at-home message for this presentation is thyroid autoantibody positivity does not automatically mean disease will occur. That is, it is a risk marker and not really a causative thing. TSH receptor antibody, especially thyroid stimulating immunoglobulin, is a disease inducing. So a novel therapeutic agent, which is not directed against TSH receptor, it's directed against IGF-1 receptor, has emerged out of thyroid autoantibody research. So when you see or hear causal inferences between thyroid autoantibodies and disease, extreme care is required. Thank you.